Dear audience, let me present our research about antibiotic prophylaxis for ERCP. So, cholangitis can occur up to 10% after ERCP. It can result into sepsis with an unacceptably high rate of mortality. Therefore, it's not surprising that it's an important question among gastroenterologists whether to use antibiotic prophylaxis to prevent cholangitis. In our systematic review and meta-analysis, we found a clear tendency for the preventive effect of antibiotics. However, due to the high heterogeneity, because of the differences in the underlying diseases of the population and the differences in the procedure itself, mathematical significance hasn't been reached yet. So based on our data, everyday use or general use of antibiotic prophylaxis is not yet justified. Gastroenterologists are urged to perform research and clinical trials in order to find a specific subpopulation and treatment where the antibiotics can be beneficial, and policymakers should allocate funds to stimulate research in the field. My name is Kálmán Zsigmond. I work as a medical doctor in the Military Hospital of Budapest. My vision is to increase the safety of ERCP procedures, and in order to achieve that, I would like to perform research to prepare the patients properly for ERCP and to decrease the rate of complications. We have two ongoing projects. The first is investigating the question of antibiotic prophylaxis by the methodology of a systematic review and meta-analysis. The second one will be a study protocol for randomized controlled trials in this question. So the first one is investigating the safety and effectiveness of antibiotic prophylaxis for ERCP. ERCP is a high-risk procedure which can have several complications. One of them are being infections, especially cholangitis, and it can be quite severe, as mortality can reach up to 10%. Based on current guidelines, antibiotic prophylaxis is only recommended for high-risk patients, and it is not recommended routinely before every ERCP procedure. However, the data here remains controversial. So our aim was to investigate the significance of antibiotic prophylaxis for ERCP. The clinical question is similar. We used the PICO framework. The intervention was the antibiotic prophylaxis, the control with no antibiotic. Our main outcome was cholangitis, and we assessed several secondary outcomes too. Our hypothesis was that antibiotic prophylaxis decreases the risk of infection. We did our systematic search in 5 databases. We ended up with 5,600 results, and after the selection process, we ended up with 14 eligible full-text articles. So we would jump to our main outcome, which is cholangitis after ERCP. It's important because if we can prevent cholangitis by using antibiotic prophylaxis, we can further reduce the complications which arise from cholangitis, like sepsis, the length of hospitalization, and even mortality. On this first plot, you can see in the left column the patients who received the antibiotic prophylaxis. On the right, and the patients in the control group who did not receive, the event rate showed the number of cholangitis in each group. We have 10 randomized controlled trials assessing this question with roughly around 2,000 patients. And the heterogeneity is moderate with a high confidence interval, is probably due to the differences in the underlying disease of the population and differences in the ERCP procedures too. The results are shown as risk ratio, which is 0.58, which means that by using antibiotic prophylaxis, there can be seen a 42% reduction of the risk of cholangitis, which is a clear tendency of the protective effect of antibiotics. However, it does not reach mathematical significance. The strengths of our study is that we analyze randomized controlled trials aiming for the highest level of evidence. This is the largest meta-analysis done in this topic so far with around 2,000 patients. A limitation can be that a lot of the RCTs are quite old, and there has been a significant change in the technology and the indication of the ERCP procedure itself. And the studies report really limited data about their patients, so we were not able to do proper subgroup analysis to find a specific population which benefits the most from the procedure. So as a conclusion, antibiotic prophylaxis may reduce the risk of cholangitis after ERCP. However, its general use is not justified, and clinicians should consider antibiotic prophylaxis for high-risk patients. And there's clear implication for research, as we should identify the risk group who benefit the most from antibiotic prophylaxis. Regarding our progress, we are doing the grade assessment and after the manuscript writing. And the second project is investigating the effectiveness of antibiotic prophylaxis in patients with biliary obstruction after undergoing ERCP. So as I've told you, cholangitis is an important complication of the ERCP procedure. But when do we do ERCP? So our main indication is that we have a biliary obstruction. It can be of benign reason, for example, a bile duct stone, or a malignant reason, for example, the pancreatic carcinoma is obliterating the bile duct. So as you can see, there has been a change in the ERCP procedure. Like in the 90s, it was used as a diagnostic tool and a therapeutic tool too. But recently, it's reserved for therapy, as we have really good imaging techniques in diagnosis like MRI, CT, and endoscopic ultrasound. The majority of the RCTs that we analyzed in the meta-analysis in our first project come from this era, where the ERCP was used for diagnosis and therapy too. So our aim is to investigate the significance of antibiotic prophylaxis for ERCP in patients with a clear indication of ERCP with biliary obstruction. The inclusion criteria will be adults with biliary obstruction proven by abdominal ultrasound, CT, MRI, or EUS. We would exclude patients who got antibiotic within 1 week, show sign of infection, cholangitis, had undergone previous ERCP sphincterectomy, are pregnant, and are allergic to the chosen antibiotic. So after we draft our protocol, the next step is with the statisticians to do sample size calculation. So to sum up, we'd like to finish our first project and submit it this September. And after that, here we would like to finish our second project too. I would like to finish with a quote from Abraham Lincoln: "Leave nothing for tomorrow which can be done today." Thank you very much for your attention.
Thank you very much for this nice lecture and talk, and this is open for discussion. Is there questions from the audience? Everyone is extremely tired. Me too. Rather a remark than a question. I don't think that there would be anything like tendency. Anything can be significant or not significant. And how do you define that something there is a tendency of? You know, that's why the p-value is defined. So,
yes.
So if something is, then you calculate the number needed to treat further or something, but I don't understand that tendency.
We can do that. I mean, we can calculate the number needed to treat is like 38 patients to prevent one cholangitis. The tendency is quite statistical nomenclature. We can see that it favors, the numbers favor the antibiotic prophylaxis. So with antibiotic prophylaxis, we have less cholangitis. But the difference is not statistical significance. We try to dig deeper, and this is a limitation of our study, because we have really little data about the individual patients. So, for example, we try to analyze the patients or the studies where they clearly set that they did the ERCP because they proved a biliary obstruction. And in this case, we have seen further reductions, like the numbers favored even more the antibiotic prophylaxis, but still not statistically significant. So as we narrow down for further that we do properly the ERCP, the numbers try to reach that we have really favored the antibiotic prophylaxis. So it shows that there will be some patients that will benefit. We have to find a subgroup for it, but these RCTs are not able to tell us that. Maybe if we can provide and do our prospective study, maybe we can answer this question.
Don't you think that it's a pre-study bias? It's a bias that you want to prove that it's going to be statistically significant.
Or maybe no. We prove it's not.
Mm-hmm. Did you take cultures for bacterial culture? Did you culture at the first ERCP? Did you take bacterial cultures?
I mean, regarding the first project, did they do cultures? Mm-hmm. Yes, there's a lot of data of what kind of bacteria they grow. I mean, it's really they are older studies. They in different regions from the world. You can see a significance in E. coli, but this does not show us any plus information.
So you don't think that it's worth doing?
In everyday practice, yes. Mm-hmm. If cholangitis, you should, mm-hmm. and it's in the guideline that we should take cultures. Plus that, there were a newer study that there's a benefit that if we do simultaneously, so after ERCP, we see signs of infection, and if we do the bad culture, and previously we did a bile culture during the ERCP, mm-hmm. there's a benefit for that too.
Mm-hmm. Okay, thank you.